You're listening to On the Ear, an audiology podcast sponsored by SpeechTherapyPD.com. I'm your host, Dr. Dakota Sharp, AUD CCC-A, audiologist, clinical professor, and lifelong learner. While I primarily work with pediatric cochlear implants and hearing aids, I am absolutely intrigued by the many areas of audiology and communication in general. This podcast aims to explore the science of hearing, balance, and communication with a variety of experts in hopes of equipping you to better serve your patients, colleagues, and students. So let's go. We are live and on the ear, brought to you by SpeechTherapyPD.com. For children and adults with profound hearing loss, a cochlear implant is a proven and effective tool for restoring audibility. We know how to counsel patients and families, how to program the device, and can reasonably estimate what outcomes are to be expected. Of course, it works by way of bypassing any damage to the cochlea and stimulating the auditory nerve, but what if the problem exists at the level of the auditory nerve? How does this change our approach with a cochlear implant? Well, today's guest is going to explain just that. Dr. Melissa Anderson, AUD CCC-A, is an audiologist and clinical assistant professor at the Children's Cochlear Implant Center at UNC, aka one of my amazing coworkers. She received her Doctor of Audiology degree from the University of Florida. Go Gators, I think. And her interests include patients with cochlear nerve deficiency and other complex anatomies, as well as advanced mapping techniques. She's also interested in ways to expand telehealth options in audiology to help reduce barriers to care. Just to note, I'm host of On the Ear and receive compensation from SpeechTherapyPD.com, and Dr. Anderson received compensation from SpeechTherapyPD.com for her contributions to today's presentation. So, Melissa, I've been nagging you to join me for an episode, probably within the first few months of me starting at the CCIC, and we're finally here. Thank you so much for joining me.
Well, thank you for having me.
So this is a topic that I think interests so many people, not just cochlear implant audiologists, but students especially. They always want to know more about the complex cases, and they want to bring those up. And I feel like C&D, when it comes to the cochlear implant world, is up there with about as complicated as you can get. Is that fair to say?
Yeah, I would think so.
So tell me a little bit about how you came to work with cochlear implants in the first place. Before we get into sort of we know cochlear implant audiology is niche, but being like a C&D, CI audiologist is the niche of the niche. So how did you even get into cochlear implants in the first place?
I got into cochlear implants. I've always wanted to do cochlear implants since I was 14 years old. And I heard about them actually through an audiologist at the Children's Cochlear Implant Center back before it was even called that. And immediately just was amazed by what that technology could do for people with hearing loss, or especially those more severe hearing losses. So even just in high school, started kind of looking into them and learning more about them, carried that through all the way through grad school, and then kind of fell into programming C&D just by chance. Just had a lot of patients who had C&D, and then just kind of expanded that into research and ways to better help them, and just kind of learn more about that malformation and how we can still help them with sometimes with a cochlear implant.
Yeah. So at the time that you were, and I mean, we're like near the same age, so you've been doing this a little bit longer than I have, but at the time, I mean, was there a lot of information? What kind of background did you have on C&D kind of in those first few cases as they were coming in?
Not a lot. There wasn't much research out at the time when I first started seeing cases with C&D. There's definitely been more and more, as we've learned more as a field just about cochlear implants in general, and more complex anatomy. I think more people are being more willing to implant patients with C&D, because historically that was considered to be a contraindication to the device. And honestly, I just kind of started experimenting a little bit with mapping and doing things that made sense when you kind of think through it, but just kind of trying and seeing what helped and what worked, and had some successes, and just kind of kept moving forward with that.
Awesome. I'm hoping tonight we'll have a chance to kind of dig into some of those like interesting mapping techniques and things that have been working for you. Before we do though, so we probably I would assume listeners have at least a background of how a cochlear implant is providing sound to someone. But what do we need to keep in mind as it relates to stimulation for someone with C&D? Like, what is happening physiologically that's different in that case that we might need to explain to a patient or family?
So I think the biggest thing is thinking about where that stimulation goes once it leaves the cochlear implant. So we're sending that electrical current, where is it going? And essentially it's going to the nerve. So if there isn't a nerve or that nerve is reduced or smaller, how is it going to get to the brain? And I often talk to patients about it being a bridge. So the nerve is the bridge from the ear to the brain, or in this case, the cochlear implant to the brain. So if that bridge is damaged in any way or not there, that's going to compromise the signal's ability to get there, or this, speech's ability to get there. And I think that's the biggest thing you have to think about with C&D and cochlear implants is how damaged is that bridge? And that's really kind of the biggest piece in C&D is thinking about it that way.
Gotcha. Yeah, I think that's a helpful like visual for people to hold on to help, because again, that's probably one of the biggest things. And I guess this is a good thing to transition to. Actually, before I get to that, but more just thinking like counseling aspect of it. With cochlear implants in general, there's a ton of counseling, but definitely with these more complex cases. And I think you're so right too about where is the stimulation going, because for patients with C&D, I mean, they're more likely to have other malformations too. That might mean
Yes.
that their cochlear implant isn't exactly in the same place that it's supposed to be, or that it might be for someone with normal anatomy, like Charge, for example, they might have a cochlear malformation plus C&D. Have you
Yeah.
seen much of that kind of combination?
Yes, absolutely. If you have C&D, you are more likely to also have something going on with your cochlea. I think, and I don't have the exact percentage off the top of my head, but the percentage of patients that only have C&D is pretty low. There's generally speaking
Mm,
something else going on. So, are you using a shorter array? Is there not full insertion? Is the position of the array not as maybe ideal? Are you kind of having to overcome some of those other things? And then you mentioned Charge. There also is for patients with C&D, they are much more likely to have a syndrome than to be non-syndromic. So syndromes obviously come with not just other things with the ear, but other things with the whole body. So is there any kind of cognitive delay, other physical needs that they're having to overcome, which obviously
mhm.
can affect the potential for outcomes.
Gotcha. Yeah, good thing to keep in mind. And that actually kind of leads me into a little bit more of like the counseling discussion. Because I mean, as audiologists who work with cochlear implants, I mean, we see children super, super young. I mean, they're often referred to us well before they're even, you know, insurance or FDA wise allowed to get an implant.
Right.
Oftentimes we'll get that referral before imaging has even happened, right? So we might not know, family might already be on this kind of like, oh, here's our expectations for an implant, and
Mhm.
then get imaging news that kind of changes how we have to counsel that. So, would you mind sharing kind of what that process looks like? Like, how do families find out about their nerve status, right? Like, how does C&D get communicated, I guess, to the family usually?
I think it's probably quite the spectrum of how they find out with, you know, kind of online medical records that people have access to. Sometimes patients find out the same time as us or even before us because they'll go
Mm,
see, a radiologist reads it, publishes his report, and can be sent to the family immediately. So I don't think it's uncommon in this day and age of that kind of electronic medical records that you get this phone call, hey, my imaging says this, what does that mean? And so then you're kind of having to play catch up because maybe you haven't
yeah.
read that imaging report. I've certainly had patients who have arrived in my office who did not know about their imaging. And so I'm the one who's having to kind of break that news and do that counseling, which especially kind of like you mentioned, if I've already seen the patient for a cochlear implant, like that initial eval, and we've
Hmm.
done some counseling, we've talked about some things, and then, talked about potentials for outcomes, then they go get imaging, then we have to have that discussion afterwards. You kind of find yourself backtracking, which can be difficult. I think in a perfect world, everyone would have imaging before they got to us, but I won't speak for other hospital systems. But getting in for an MRI is not an immediate thing, at least in ours or any that
Yeah.
I've worked in. So sometimes we do see them first and then have to kind of, okay, now we have to have this imaging discussion. Obviously, sometimes it's the surgeon who is, having that discussion with them. But I think the bulk of the counseling in terms of what outcomes to expect, what language modality to choose, a lot of that is coming from the audiologist. And when you think about language modality, the speech pathologist as well.
Yeah, absolutely. Yeah, that's actually one of the things I'm hoping we'll touch on tonight too, is kind of the what the team looks like when in managing kids with
Yeah.
or kids. I should say kids and adults with C&D. You and I both exclusively work with kids. It's so hard to like
Yes.
not be in that mindset.
Yeah.
So we're just gonna have this conversation be mostly pediatric focused.
Yes.
Okay, so then what? I totally agree with you. My hope would be that their managing physician would be the one to discuss, their nerve status, right? But oftentimes, or I shouldn't say oftentimes, but sometimes it falls to the audiologist. What does that conversation look like for you? I mean, how differently are you having to counsel, expectations in this situation?
I think when I have a patient who's diagnosed with CND that I'm kind of the one breaking the news, I really like to spend a lot of time talking about ear anatomy more so than I would for a patient who has normal ear anatomy. I might just kind of like, okay, outer middle. Okay, now let's talk about your inner ear and then talk about cochlear implants and don't really spend a lot of time talking about the actual like ear as much versus with
Hmm.
C&D I'm like pulling out the picture of the ear, we're walking through all of it and we're talking a lot about the nerve and how important that nerve is,
Hmm.
and then talking about the imaging results. Okay, so now that we know that we don't have this nerve, that bridge is not, fully functional, now we got to talk about what a cochlear implant can do and what it can't do. And you just
Hmm.
spend more time talking about kind of what it can't do. And
Yeah.
I think the biggest thing when counseling that is knowing that that's a lot for a family to process. So there's definitely been times where I've just kind of had to just stop and just sit there and, sometimes parents cry or just need a moment to process, need a moment to talk with each other. So sometimes I'll ask families like, do you just need a moment? I can just step out, or just
Hmm.
kind of it depends on the case and how fresh that news is and what they've been told about cochlear implants. Because the other thing, at least for a lot of our patients, they've already been in touch with early intervention or beginnings. Two groups in North Carolina that kind of go in and chat with families. So they may have already heard about cochlear implants from a professional outside of kind of what you would think of as the more
They're
immediate team.
amazing. They're easy
Oh,
peasy. You know.
yeah. They're going to get them
Which,
and
by
learn
the
how to.
way, is mostly true, right? We don't want to get
Yes.
a bad rap here, but I'm with you. Yeah,
Yes.
definitely
Yeah.
expectations can be swung hard in a direction that's not very
Right.
realistic before we know. We kind of
Yes.
what's the phrase? Like you put the cart before the horse a
Yes.
little bit in that one.
Yes.
Okay.
Yep, exactly. So sometimes you're having to be like, well, that is true for most patients, but for your child, and that's always kind of a difficult conversation too, because no parent wants to hear that their child is different in that way.
Mm-hmm.
They want to hear that their child's going to be fine. It's going to talk like that kid that, that person was telling you about, or that kid they saw in the store. That's what they're looking for a lot of times when they
Yeah.
come into our office. So breaking that news that that's not really feasible can be really difficult. And so it's just kind of letting the family process that. And then I tried to do this with my patients in general, but definitely for ones with C&D is kind of make sure we do have that second touch point, or sometimes third or fourth touch point before surgery, just so that way we're all on the same page. They've got to ask all their questions, as they're processing everything.
Yeah, and I think that's a good point too. I think back there's an episode with a parent that kind of talked about the grief process and the acceptance of their child's hearing loss.
Yep.
So you have to imagine some of these families have kind of been on that journey. They've maybe had some acceptance and are now hopeful, right? Like they've gone through
Yep.
the that
Exactly.
phase and now it's like a whole new thing to deal with, right?
Yeah.
A whole new blow to their expectations, right?
Yep.
So yeah, that definitely can be a difficult part of the conversation. I mean, these days, I mean, maybe it's evolved, but what do these days do those conversations about outcomes look like? Like, are we? It's so variable. I know that's probably
Yeah.
going to be your answer too, right? And that we
Yeah.
can that's somewhat true, and it used to be more true for cochlear implants in general. Now we can like really swing way more on the positive outcomes. Where are we right now? How has that conversation evolved for you? Maybe from the first few cases you had to today, in terms of what you say about, okay, this is what you can expect for your child.
I think when I first started with this, it was much more like they're going to get nothing from it. We can do this if you really want to, but like they're not going to hear. And I've kind of more evolved in that there is a pretty decent chance for sound awareness. And, the research that I participated with at various other people at UNC, that we're looking at about 60% that get at least something. So now that
Hmm.
might just be sound awareness versus speech perception.
Yeah.
But there is advantages to sound awareness from a safety perspective. They're going to hear that fire alarm. They're going to hear that truck coming up behind them. They might be able to hear that someone's calling them. And then going all the way to, we do have some patients that have full open set. And while there are some variables that are predictive for that, certainly not predictive enough that I would counsel someone like, oh, we saw this on your MRI, you shouldn't get one. And I mean, there are
Yeah.
situations, especially when you think about cochlear malformations, where you have C&D in a super, super severe cochlear malformation where we might not even be able to get the cochlear implant in. Obviously, those patients aren't candidates, but For a lot of patients, it is worth the shot to do it. It's just making sure the family is really fully informed about that this is a gamble. We don't
Yeah.
know. And that's something I think I find myself saying a lot in my C&D counseling is that we don't
Mm,
know. We do not know how well they'll do. And even 3 or 4 years into the process, when you think about a little baby who's getting this, it might be 5 or 6 years into the process before we really know what their potential may be because
mm,
language development hasn't happened yet. So
sure.
it's hard to know when you're going to hit that plateau.
Yeah, that's a great point. I think when we think back to the imaging conversation too, how that plays into expectations, because you might have somebody where the radiologist, whoever, describes the image as like cochlear nerve aplasia. There's no
Mm-hmm.
nerve at all, right? Or we hear families will bring in the term, and we use the term of a wispy nerve, right? Like there's a
Yeah,
little
yeah, yeah,
something there, right? And I think those maybe don't affect outcomes as much as we predict. Is that fair to say? Like, just because
yeah.
it's read as cochlear nerve aplasia doesn't mean you might not still have, detection or whatever we can expect from that ear, right?
Right. And so that's again, when we go back to some of the research that I've participated in, if you have aplasia versus hypoplasia, you are more likely to be one of those non-users or not
Mm-hmm.
have STEM. That being said, one of my patients who does pretty well with his implants. He's one of those kids who does have open set. His imaging read aplasia. So even though it is predictive in the sense that you're more likely to fall into that group, it
Mm-hmm.
doesn't mean you will. There are those kind of we teasingly call them unicorns. There are all those unicorns
Yeah.
who do surprisingly well despite what their imaging says.
Yeah.
Uh,
And this is one of those tricky categories too. I'm curious how it plays into your counseling discussion with families. Like, do you find yourself wanting to mention the unicorns, or do you find yourself not wanting to? Like, how much do you want to, impact
yeah,
expectations with these miraculous stories, right? Like, we want
yeah.
to share these, but we also don't want to have, false hope or, poor expectations.
Yeah, and that's I struggle with that, especially when you see these families grieving. I just think, you know, I'll speak for myself. I got into audiology with the desire to help, and I think a lot of people did,
Mm,
right? That's what you want to help patients, you want
yeah.
to connect with these families and bring them that hope. I mean, that's a lot of what cochlear implants is, right? It's like get this technology, there's hope that your child will talk. And with C&D, you have to kind of war with that inside yourself that you don't want to give too much hope because one of the big things that you recommend is also a visual language. So if you're like, don't worry, your child will talk, but also you need to sign, that's kind of mixed messaging. So I spend a lot of time talking to families. The when we look at patients, one of the most likely outcomes is just sound detection. So I think
Yeah.
I spend a lot of time talking about that and then talking about that even if they do get a little bit of speech, it's not going to be full open set. It's going to
Yeah.
be, maybe they have some common phrases, maybe they can understand their name, those types of things that would be like best case
The
scenario, they
goal.
might
Yeah.
get that. But most realistically, they're going to get some sound awareness. And that is
Yeah.
where I do use the imaging piece too. For the kids that are aplasia, I'm like, they may get sound awareness, they may get nothing. And I kind of focus
Yeah.
more on that versus hypoplasia. You can kind of also talk about like maybe a little bit of open set. And it's just kind of counseling the families very realistically because I would rather have somebody pleasantly surprised that their child can speak than upset that I had promised they're going to do something that they're just never
Yeah.
going to be able to do.
That's a great point. That's a great way to approach the counseling too. Where do you find most families are kind of on that spectrum? I guess maybe when they first see you. Hopefully by the time you're done talking to them, they're very much on the realistic expectations route. But where do you find just kind of families these days are at in that process when you first kind of describe what to expect?
I think when they first come to see me, a lot of them they just don't really understand what it is. So,
Mm,
even if they've read that imaging report, they're like, we didn't really know what that meant. And then you have kind of the other end of the spectrum where you have the families who've Googled what that meant and they're like, well, what's the point of getting this? So
yeah.
it's it's really just educating about what it is, what it can do, what it can't do, kind of really, really, really basic. And then as we go through the process, I feel like I start getting the questions of like, so will they ever be able to talk? Will they ever be able to hear me? And you kind of have to say, well, we don't know yet. And that's kind of
Hmm.
going back to, like I said, I feel like that is probably the biggest thing that I say in those counseling appointments is I don't know.
Yeah.
which is always an uncomfortable place, I think, for healthcare professionals to be. We want to know,
Absolutely. Yeah.
but we just don't.
Yeah. So, kind of thinking back to that aplasia, hypoplasia, just like the imaging aspect of things, I feel like it's something that's pretty often overlooked in the audiology world. Like in my schooling, we didn't really talk about what you might see. You talk about MRI versus CT, like literally what are the differences there, but not like what are the physicians looking for and how is that going to impact what you expect with this, XYZ. You talk about syndromes and they might cause this thing, but you don't really get too much into like the imaging aspect of it. I'm just curious how that has played. I just feel like as people who work with cochlear implants, it's on my mind all the time. Like, okay, I know you have this malformation, so that's going to impact, like, that could impact, what your programming looks like and what your outcomes could be. And I'm curious how that's played out for you, just in your role as an audiologist in implants. Where does like imaging kind of fit into the picture for you, C and D or not?
I think it's something as I've gone through my career, I've put so much more importance on just as I've learned more. And then
Mm,
just my interactions with surgeons and things like that, that like, I would say just in general, in my day to day, when I go to like see a patient, just any patient, I like, look through the past notes and see what we've done. And then I'm like, and what was your imaging? Because whether
yeah.
it's something more simple like EVA or something more complex like C&D, like I want to know that before I walk in. So I think even just some patients who, I may have seen, but it's been a while, it's like, I want that refresher on what your imaging is. And then I've also found myself like, because we work with students. So I'll have grad students who are working with me and I'm giving them the history and the patient. One of the first things I tell them is the imaging. If
Yeah.
it's abnormal, I don't usually specify if it's normal. But like if
Yeah.
we're like, hey, we're going to go see this patient, they're IP1, or we're going to go see this patient, they're C&D. And I just find myself using those terms with students more and more and more as I've
Hmm.
moved through my career. And then I think I'm also counseling it a lot more than I ever used to with families. Because I think when I started, it just wasn't something that was on my radar as much. And
Totally.
now, before I see a family for the first time, I'm like, I want your imaging report. And if I don't have it because they haven't had their scan yet, I spend a lot of time on my counseling being like, pending imaging, with a little asterisk to everything. Like,
Yeah,
we're going
yeah,
to check
yeah,
with this. However,
yeah.
so I think it has become much more prominent in the field, probably as a whole, but definitely for my own personal work is kind of the reliance on that piece. And just even my communications with the surgeons are very imaging aware, I guess. It's like, okay, we
Hmm.
need to talk about this before we do XYZ. Let's look at the imaging before we do XYZ.
Yeah. So on that note, who is primarily making up the team? If you're thinking of like a child with C and D, you mentioned they're more likely to be syndromic, so we'll probably have other professionals involved. Like if you have a case that comes to mind, like what kind of professionals are you having to keep communication with to, provide really good care?
Yeah, so I mean, you have kind of what you think about as your kind of core team: audiologist, surgeon, and speech language pathologist. If we're looking at a child under 3, we're incorporating early interventionist, a child at school age, school audiologist, school speech pathologist, teacher of the deaf. But then you also kind of have to think outside of that, because that group that I just mentioned, those are people who probably have a better understanding of what C&D means. So they know, okay, they have a cochlear implant, but they have C&D.
Hmm.
That's going to mean this for outcomes. But a lot of these kids also are working with PT, OT, behavioral therapists. They might be seeing ABA therapy, lots of other medical professionals. It could even be, neurology or
Yeah.
nephrology or any of those. But especially thinking about the therapists who are working more like day to day with those patients. So, like a PT who might be seeing them once a week, they might see a cochlear implant and have enough knowledge to know, like, oh, they have a cochlear implant, they're going to learn to talk, they can understand me. And you have to be like, whoa, 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 no, they can't. Like, they
Hmm.
have C&D. And so you might find yourself just kind of similar to how you had to counsel the families, you have to also counsel these other therapists who are working with them
Yeah.
about, again, what it can do and what it can't do. And these be kids who can't understand, they're not going to talk. So just giving them that information, because I think as cochlear implants have maybe become more mainstream, people kind of, especially therapists and things like that, might see
Yeah.
it and be like, okay, this is what that means. It's like, no, 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 not for this kid.
Yeah, I think that's a great point. How about that relationship with the otologist or the managing cochlear implant surgeon? How early are these conversations happening? And like, are they different than what it would be for a child who with typical anatomy who's getting a cochlear implant? Like, is there more communication? Is there more to the device selection aspect of things? Like, how does that differ?
I definitely think there's more communication. When it's normal anatomy, I feel like the surgeon is just like normal anatomy, and we're like, okay, good, and then we move on. There's
Yeah.
not really a much more discussion than that.
Yeah, yeah.
When you think about anything more complex, there is slightly more discussion, but with C and D for sure, because now we're looking at, okay, what array might fit in the cochlea that's also
Hmm.
malformed, or what device might help this child keep it on their head. So there's some syndromes with that have seen kind of as part of the syndrome that also can affect head size and things like that. So you have to think about like,
Pinna size, right? Do we have something that the
oh
cochlear implant can
yeah,
sit on, right? Yeah, totally.
right. But head size, do we need to make those coils a little bit farther forward so they don't
Yeah.
interact? Because when they're farther back, they could interact. That's something that you have to think about when you're programming too, is watching your power settings, because when they're both on, they might, you get those little warnings.
Interfere. Yeah.
Yep. So those are conversations that you have to have with the surgeon, is like, hey, this kid's head's pretty small, maybe let's scooch those forward. Or some of those kids, again, with syndromes and other things, if they're in a wheelchair, you have to think about that in terms of device placement,
Mm,
and then as well as what arrays might fit in their cochlea.
sure. That's a great point. I wonder too, did those similar kinds of conversations happen with the family? Like, you're talking to them a lot about expectations, right? That seems to be a big
Yes.
frame that we have to get through with families when we're talking about C and D. But what about when it comes to not so much like outcomes, expectations, just more like, here's things you're going to need to consider with your device that other families might not be dealing with. One thing that I think of is like these kids we might have, and we're going to get to mapping in a minute here because I don't want to forget that. But you might have a very, very, very wide pulse width, and you might be pulling a lot more, battery than, a typical cochlear anatomy case. So do you have to talk about like, you might need this other kind of battery or an extra battery source, or, how does that kind of play into those conversations?
So I think it also depends on the family, because there are some families that by the time you get to device selection, they are so overwhelmed they just really want you to kind of make some of those choices for them, which, not that you want to pick for the family, but you can kind of help them along that a little bit more, kind of a little more hand holding. In terms of battery life with any of my patients with C&D, I know the companies love to talk about smaller batteries and things like that, but that is not for this population. You need the
Yeah.
biggest battery you can get that's going to have the most juice, because these are going to take more power, generally speaking. So I think for me, when I'm counseling, I'm like, okay, and we're going to get you this battery. It's a little bit bigger, but it's going to get the job done. The other one's not for you. Like, and just kind of take that off the table as a choice, because I know that's not going to work for that family. So sometimes that's a more of a conversation, sometimes that's less of a conversation. That depends on the family. When you get that, I'm going to throw out an audiology stereotype, the engineer dad,
Hmm.
you're going to have more of a conversation about that than you will, a parent who's maybe just very overwhelmed, deep in that grief process. They're just like,
Yeah.
whatever, bigger battery sounds good, great. And
Yeah.
then so I think I kind of leave that up to the family, how in depth they want to get about why they have to get the bigger battery, but the bigger battery is what they're going to get.
Yeah, that's a great point. I didn't even think about that. How much how much every company is going to promote their teeny tiny little battery, and in
Yeah.
this case it's like, just forget that. Just ignore that. We need to make sure you can stay on for, hopefully as much of your day as possible. Okay, so let's just imagine we've had the referral, we've got an implant candidate, they've got C&D, we've got our imaging that's confirmed it, we've built up our team. They go through surgery, all goes well. Okay, it's activation day. You got your backpack out, you got your little stuffy, you're ready to roll. How does what you're doing in the mapping software differ on activation day for a child with C&D versus a child with typical anatomy? Are there differences?
Yes. So again, kind of going back to the counseling piece, I kind of counsel everybody on activation day, like any response is normal. They may cry, they may laugh, they may not react at all. For my patient with Sandy, I kind of stress the not react at all part a little bit more. And what I kind of, and I talk to families about this beforehand, but then I emphasize it on activation day. It's like, give me at least 3 months to try and see if I can get them hearing something.
Hmm.
If at the end of 3 months we're still not hearing something, we'll have a conversation about that and just kind of see where we're at, and just kind of try to get families to at least commit, because it's really common with these patients for the families to just kind of get discouraged and then they're not
Mm,
wearing it. And wear time is an issue across pediatrics in general, but especially for this population because
sure.
they aren't seeing those benefits. It's like, no, no, but if you don't put it on, we can never know if there would be a benefit.
Yeah.
Um, and then again, you're dealing with a lot of kids who are syndromic, so keeping it on is even harder. So that's one of the things I talk about that a lot at activation. In terms of the mapping, slowing it down is never a bad idea, just kind of bringing the rate down a little bit. But the biggest thing is just being prepared to go louder than you normally would. When you think about
Yeah.
activation maps, it's like, I don't want to overstim. And you can, especially if you're kind of not getting much from the patient, but they have normal anatomy. I tend to be like, okay, I think this is kind of a good place to start. This is kind of an average starting level. With C&D, it's like, okay, let's turn it up. Let's, give it a
Hmm.
shot because they might need that much higher stem. And then for some companies, if you go higher stem, you might have to look at widening the pulse width. So just being prepared to do that more. And I always tell students when you think about mapping C&D, it's like you take the rule book of like what you do with cochlear implants and you kind of toss it out. C&D has its own rule book, and one
Hmm.
of those is higher stem level. So I'm less concerned about over stem necessarily at activation because there's not much to over stem.
Yeah. And I mean, I guess the basis for that is just you've got kids who have these functional maps, right? And they are
Mm-hmm.
older and they're maybe even old enough and have the language, whether ASL or spoken, to give you feedback like,
Yeah.
oh, that's too loud. And we see enough of those and they're at higher
Oh yeah, they're
levels,
at
like
higher
much
levels.
higher
Yeah.
levels. Yeah.
Yeah.
So we can
Totally.
have a little more confidence on activation day to work things up. I like that you also mentioned on activation day. I mean, I'm guessing you're having to devote a little more time to establishing retention. So what
Yeah.
does that look like on activation day? What are you finding that's, effective for these? I guess, it depends on everybody and what they look like, but
Yeah.
and their age, right? Is it going to sit in
Yeah.
their ear or not? But let's say we've got like, 10-month-old, C&D, we've turned things up, we've slowed down the rate. How are we keeping it on their head?
Yeah. So I mean, I think for kids who don't have anatomical difference elsewhere on their head, it looks fairly similar to those without C&D. It's just finding a way to hold it on. It's just some of these also do have, smaller heads, maybe malformed pinnas. They're in a wheelchair. So I feel like this population I'm using like clipping the processor to their shirt or to their hair, or like
Mm,
I have, some kids we clip it to the back of their wheelchair, like on their wheelchair headrest. You like can clip it back there. As weird as
mhm.
that sounds, obviously when that kid leans forward, it's going to come off, but it's for that patient, that is the best way to hold it on. So I just feel like you have to be more willing to take it off the ear for this group of patients. But that has less to do with C&D, more to do with what might be comorbid with C&D.
Sure, sure. Any other things that come to mind when you think like initial mapping things? Like, would you still want to use progressive maps? How do objective measures play in with this population? Is that any different for you usually?
In terms of objective measures, I don't do a ton at activation just because I want to just kind of send some signal into that nerve and just kind of like, or whatever might be there from that nerve,
Sure,
whatever little
yeah.
nerve fibers might
What
be
we
there.
hope is a nerve is there.
Yes.
Yeah.
And just kind of try to get that, just kind of use that simulation. And then we see patients back at 2 weeks. I like to kind of take a stab at some of those then. In terms of progressive maps, I think it kind of depends on where we're at. I'm more likely, I mean, there are a lot of patients that you get that response. It's like, okay, let's do some progressives. This is the first hearing. Let's do some progressives and see if we can
Hmm.
work our way up. There are some patients that, because of compliance and some different things, you might end up setting maps that are different in parameter
Hmm.
versus different in just stim levels. And
Sure.
so you kind of have the family work through it. So it's kind of a different conversation when it's that's like, give these a try, see which one you think they respond to best. Leave it on each program for 3 days and then see what you feel like you got the most responses on and come back and tell me. And then we can kind of use that to build a map. When looking at kind of the later appointments with objective measures, like that next appointment is usually when I like to pull those out. When thinking about ECAP, you would actually be surprised how many have something. Are they pretty? No,
Mm,
they're not. They're certainly not the classic response that you are used to seeing, but sometimes you can kind of get something. And I can definitely use that to kind of guide my program, especially if you kind of run it with some different parameters and some different things like that. It can definitely
sure.
guide, okay, this is where I prettiest response. This seems to be the setting that nerve kind of locked into. Let's build based on that.
Okay.
And then I would say you would also be surprised how many actually might have some ESRT. I think we're still learning how to use that. Is it, do you use that the same way for a C&D patient as you do for a patient with normal anatomy? I'll be honest, I don't have the answer to that yet,
Yeah.
but I have found it on some of my patients. Now, those are the patients who I've been successful with getting it on thus far, which this is completely subjective, happen to be the ones who are stronger performers. So that obviously that makes sense, right? Like there's
Yeah.
obviously some amount of nerve that's responding to allow you to get that measure. It's just, how can you program using that? Is it the same? I don't think we know as a field.
That's a good point. And so thinking through if ECAP's going to be present had me thinking about different array types, basically, right? Like if we're going more perimedallar or lateral wall. And when we were talking earlier about, communication with the surgeon prior to, I forgot to mention that too. Do you find that either the surgeons have thoughts there or that you have thoughts there in terms of what you're seeing, and maybe it's easier to get whether it's ECAP present or just responses, lower levels, or you know what I mean? Do you have to, are you less likely to widen the pulse with one over the other, or how much does that play as a factor?
In terms of that, I haven't noticed a strong, I guess, like outcomes are better with one versus the other, or I'm more likely to get a response. It's really about what the surgeon can get in. So I
Mm.
think a lot of that I really do leave to the surgeon. When you think about lateral wall arrays, they tend to be, and this is from surgeons, they tend to be a little floppier versus, when you think more perimedular, they might be able to get those in a little bit better, just depending on what kind of anatomy they're up against. But really it's just if the surgeon can get it in there effectively and in the right place, and that's going to give you the best chance of success versus one array versus the other. Obviously, when you think about like a Cochlear branded device, when you go more lateral wall, you're already having to increase the pulse width. So now with C&D, you might have to be increasing it more, when you just think about what the defaults are in the system. So that is something I do kind of think about. But in terms of my conversations with the surgeons, it's really just, hey, this is the situation. We have C&D. They're leaning towards this brand. And then it's whatever they feel most confident in being able to get in, especially when you're thinking about a cochlear malformation, which often accompanies C&D.
Yeah, because like at the end of the day, it's not going to be very effective if it's not actually in their cochlea,
Right.
right?
Right.
And that is my favorite segue of the night because I'm going to segue that right into maybe the weirdest place a cochlear implant could be when it's not in the cochlea. A paper that you published and a case that you led on. I guess when did this happen? Like 2 years ago or even longer
Oh
maybe at
no,
this
it was a
point?
little longer than
Could you break down kind of what happened there
years
for
ago.
us?
Yeah, I had a patient who transferred into our clinic. Excuse me. The family's military, so they've been seen by audiologists kind of throughout the country. And he received his implant when he was 4. And he ended up getting it in both years. The first one when he was 4, and then the next one a few months later. And when he came to see me, he had him for about 3 years, 7. And when I was testing him, he could do all this stuff with his right ear, but couldn't with his left ear. And he is such a sweet little boy and such a people pleaser. And you could just see him in there trying to do the things, and he just couldn't. He didn't really know what you were asking him to do. And I'm not talking speech perception, I'm talking like condition play audiometry. So I called up the surgeon who had kind of taken on this case and asked him for imaging, and he got it for me. And it revealed that this child had a cochlear malformation. He had IP3, but then also that his left implant was in his IAC instead of in his cochlea. So it was sitting on his nerve. And he had a pre-curved device, and we were not sure if it was coiled around his both cochlear nerve and facial nerve. So at the time, it was not recommended to pull it out and reimplant because of the potential for it to be coiled around the nerve, and you don't want to pull out the facial nerve.
Mm.
So he had 4 contacts left in his cochlea. So we tried to just stem on those 4, and he basically couldn't hear anything from it. So I partnered with our wonderful research team, and we kind of came up with we basically programmed him as if he had an ABI. And so we did a pitch ranking task with him using a xylophone. So we would play on 2 channels back to back, and then he would like ding on the xylophone, whether it was like low, high, or high, low.
Hmm.
And we use that to set up a map that only had, it has 6, he's cochlear device, he has 6 channels active, which is obviously not
Very few.
ideal. And we assigned the pitches to them based on kind of what he presented and what wasn't overlapping. That's how we ended up with those 6 channels. And over the course of several months, he started being able to do, just like, yes, I hear that beep, all the way to getting open set speech perception. So he went from having no speech perception, very little or confused, maybe sound perception, to getting 56% on a CNC.
So
we
cool.
published we published the paper. We always tease we published it too soon because he had made so much progress, and we published this paper, but then the next time I saw him, he actually made so much progress that he no longer had a dominant ear. His left and right ear were doing the same.
Wow.
So it was really cool, his case. But yeah.
Yeah, that's amazing. And it makes me think about like how these complex cases, there can be so much more to it. Like it goes beyond, hopefully they're able to get the cochlear implant in. Now we also have to think, hopefully they don't overshoot it and go into the IAC around the
Yes.
facial nerve.
Yes. Yeah.
And so that kind of leads me to another aspect of this, which is kind of like, what are you seeing, years in for some of these kids? Like, how often are you running into other complications of things? Facial nerve stim, equipment challenges. Like, what are some of the big picture things you see that you would want other audiologists out there who are maybe new to working with CND and implants to know or to have in mind?
Yeah, in terms of equipment problems, I think it's very comparable to other kids in general. The kids who are more syndromic might have a little bit more of a challenge just because of other things going on in their, with their medical care. The facial stim is a big, big, big thing with mapping. You sometimes might think you're stimulating the auditory nerve or whatever fibers may be there, but you're really stimulating the facial nerve. I think the other big thing you have to think about is if you have a really compromised nerve, are you stimulating something auditory or are you stimulating something vestibular? So you have to kind of
Mm,
think about like, is that patient spinning? And that can be a really hard thing to assess in the moment. Is
especially
just
one who's not mobile yet, maybe, right?
right. Yeah, yeah. So we're talking about, kids who are sitting in a stroller. Are they
Hmm.
dizzy? Who knows? And so that can be really tough. When the kids get older and can report things to you, they might be able to say like, "Whoa, that, feels weird," or, "Oh, I'm feeling that here," or something like that. But the little babies, it can be really hard to determine that. Facial stim is a little easier because you can, see that face
Hmm.
twitch or that eye twitch or whatever it is. But you're definitely running up against that way more than you are just the general population. And it definitely can limit what you can and can't do. And so sometimes it's that conversation with the family, like, this is pretty much all we can do
Hmm.
without, this facial stimulation, and it's not working, which means there is no auditory nerve fibers responding. Everything we're seeing is a facial nerve. And so
Yeah.
that can also be a hard conversation to have. And I think that's, again, I've talked a lot about counseling. It's just the counseling process is for any cochlear implant patient is not isolated to that initial evaluation appointment. That is especially true with CND. The counseling for this is ongoing, and the family's acceptance of the CND is also ongoing, especially for the kids who might make a little bit of progress at the beginning and they're doing
Yeah.
they're starting to go, and families are like, great, it worked, we don't have to assign. It's like, no, 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 like, still use that visual language. And then you see it where they kind of hit that plateau, and then the family's like, okay, well, now what? It's like, well, we've done what we could. This is what their anatomy could do. And there's lots of things you can try, so it might take a while to kind of get to that point. And that's, I think, the biggest thing I would encourage anyone seeing any patient with CND to do is be willing to try those different things. So
Yeah.
change the rate, change the pulse width, put the stim levels higher, try ECAP, try ESRT, just try it and just kind of see what sticks, especially in pediatrics. With adults, they can give you some
They'll give you
feedback,
the feedback.
but
Yeah.
for these kids that can't give you the feedback, just kind of try and see what happens, and be willing to do that, over the course of
I was gonna say, it
sometimes
sounds like you're saying
years.
be patient, right? Like that's another
Oh,
one of those
yes.
things. Yeah, you got to be
Yeah,
patient with these things
absolutely.
too. Even
Yes.
more so, you would say, than maybe the patients with typical anatomy.
Yes, because with typical anatomy, there's a general trajectory that you would expect. So,
Hmm.
especially when, I mean, device use is good when the families are using the device and wearing it all the time. There's kind of a general trajectory. With C and D, that trajectory is not there. So I mean, I have a case I'm working on right now who's been making all this great progress. And, now we're kind of having this conversation about we're kind of hitting this plateau. There's still lots I haven't done with his map. So it's like, okay, let's try the next thing and see if we can continue progress or not. And we might try a few things and discover like, nope, this is his level, this is what his anatomy can do. I could also try it. We kind of keep making progress. So the only way to find out is to try.
Yeah, that was actually sort of one of the last couple questions I had was just kind of if there are cases. So you mentioned your unicorn with cochlear nerve aplasia who has open set speech perception. I'm wondering if any other cases come to mind, whether it's, how they're doing now for better or for worse, or how kind of the family struck you, or something that really challenged the way that you were approaching their mapping, or any cases that come to mind that you'd be willing to share about.
So I definitely have a few cases that kind of jump to mind where I've used a lot, and this is going back to talking about the importance of the team, is I've used a lot of either what a speech language pathologist told me or early interventionist has told me, or, oh, we were seeing this at school, to kind of guide what I'm doing. So it's like, they start to make progress and it's like, then when you stall out, it's like, okay, let's do this. And then, they're responding. I mean, this is one that jumps to mind, a patient of mine from a long time ago who was hearing, they were doing ling sound checks. The intervention was trying to see if they could hear ling sounds, and he was able to detect some of those lower pitch ling sounds, the ooh and the, but wasn't hearing this or the shh, which are more higher pitch. And I actually managed to get some booth testing out. He was very little. I got some booth testing out using a little VRA, and that's what I found is like at very loud levels he could hear some of those low pitch but couldn't hear the high pitches. Over the course of about 6-7 months, gradually turned off some channels, shifted frequencies onto channels that we were getting responses, and I was able to get him to be able to detect all of them. He never got discrimination, but he was able to detect over, the entire frequency range that we were looking for. So, through a lot of patience and a lot of work with different team members, was able to, get kind of max out what this kid is doing, or at least what we think was, maxing that out for him.
Yeah, I want to ask you about another case, but that actually reminded me of something we didn't talk about when it came to, mapping outside of the box with these kids, is not being afraid to disable channels, which I feel like
Yes.
oftentimes with cochlear implants, we want to like last resort that because it's like, if
Yeah.
you could hear something there, I want to use it. But no, in these cases, it's like, if you're not hearing it and I'm up at these crazy high stem levels, like you're better
Yeah.
off reallocating that somewhere else, and being willing to kind of play around with that frequency allocation table, I think is also a big part of working with this population, right?
Absolutely. And it's, again, if you think about just what nerve fibers may be there, that may affect what channels are actually working. So, and there's a lot of amazing research out there now about like space mappings and things like that. And that's great. That does not, in my mind, apply to this population. This population, it's what nerve fibers might work with some channels. And if you have, 8 channels that somehow have made connections to whatever nerve fibers are there, let's maximize those 8 channels and give you the most that
Mm,
we can. Is that
yeah,
ideal for discrimination? No, but is discrimination possible for those patients? Also, no. So, are we giving them
yeah,
the best sound awareness that we can? Yes.
that's a great point. Wow, so many tidbits in here. I'm hoping that people who are unfamiliar with this are gonna be able to like take and use. Any other cases that come to mind that maybe like from the counseling angle that you felt like are just kind of memorable families or experiences that you've had?
I have had, so actually the unicorn case, him and there was another family, they were kind of going through everything at the same time. They came to me within a few weeks of each other and got in touch. I don't know if it was through our Facebook or somehow these mothers in touch with each other, and they were kind of going through this experience together, which was great. The little unicorn boy obviously did very well with his. The other little girl, and she's now a non-user, it just,
Yeah,
she had less success. We tried all the same things. So just kind of watching the child who didn't do as well kind of compare, like, well, this little boy has CND too, and he's doing all these things. That was a
yeah,
very difficult counseling situation for me. And I hadn't really experienced that before that. It's just how to counsel that mom that, like, yeah, but everyone's anatomy is different, and
hmm,
hers just didn't work. And this little girl, I will just throw out, is doing amazing with sign language and doing very well
yeah,
with that. But a cochlear implant ended up not being for her. That was definitely just the way that mom grieved, and kind of walking her through that process and that eventual acceptance that it wasn't going to work was just a little bit more challenging, just because she has seen other kids with C and D who do well. I also, another case that jumps to mind is we have a sibling set at the clinic where they have a syndrome. One of them is more advanced, but so it's an older child and a younger. They're both little boys. An older boy. Well, they're not so little anymore. Now they're much older than I. It was like, oh my gosh, you've grown so much. But the older child, his anatomy wasn't as bad, and he had some cochlear malformations,
Hmm.
but his nerve was intact. The younger child also had cochlear malformations, but the nerve wasn't. And I think that was something for that mom that is just seeing the difference between that, and kind of counseling that it's like, yes, this child did this, but, this child may not. It was just a difference because she had an expectation, having been through this process before, that
Sure,
we kind of
sure.
had to like walk back and be like, yes, but this is different.
Yeah.
Um,
That's a great point, and
well,
it points out one of the things I feel like I find myself recommending to families all the time on their, cochlear implant journey early on is, one of the best things you can do is connect with other families who
yeah,
are who are on this journey with you, right?
yeah.
And then this is one of those times where it's like, wow, the outcomes are so variable that this could really go a whole different way than we expect.
Yeah,
Yeah.
yeah. I think C&D is probably the hardest thing to recommend, like talking to other families, because
Yeah.
do you connect them with a family that had great success and is doing really well and build expectations beyond, or do you connect them with a family that ended up being a non-user and then they don't want to go through the surgery? So it's hard, and obviously there's a middle ground, but
Sure.
it's really hard for me to like pick families to be like, oh, get in touch with this person versus, for my kids with more typical anatomy, I feel like I have all these people I can get them in touch with.
Yeah. So if you had I know we're kind of coming up on the end of our time here in just a little bit. So if you had the ear of, all three cochlear implant manufacturers, which I know you do because you're a powerful lady in the implant world, but let's say they were sitting down for a meeting just with you and they said, we know it's not, we know programming kids with C&D is not ideal right now. Or, what aspect of our device or programming, like if you could just tell them, hey, please add the feature that can do XYZ or that can account for this. Like, eh, honestly, my bigger question here is like, what do you hope for the future of working with kids with C&D and implants? But I guess also like from like a device management side, if you want to include that too.
So I think in terms of like mapping softwares, I would love to see ECAP being able to be run with lots of different parameters to be a little bit easier and maybe a little more time efficient, especially when thinking about working with kids. Because if I'm having to run it in multiple different parameters in one session with a child, and even ECAP, they can move around and do all the things, but sometimes that's really challenging just to kind of keep them like seated to do that. And then I definitely think being able to modify the frequency table is something that it's easier in some manufacturers than others, but I think having that be something that's a little bit more easier to really manipulate that would be something I would be looking for. And then just kind of different ways to manage kind of how that current is going through, just to make that sometimes a little bit more accessible, because sometimes it is and sometimes it isn't, depending on what you're trying to do and depending on what manufacturer. So I think when you think about these more complex cases, is just sometimes you really have to dig in the software, really find what you are looking for. And
Sure.
I think that makes it more challenging for audiologists as they're looking to work with these kids more. So it's just having that more accessible for those cases.
Yeah, could we look at
Yeah.
a different type of array, maybe for more complicated anatomy? I mean, I don't
Yeah, I
know.
mean, there's so many arrays out there, and so many different things you can do with the arrays, especially depending on which company you choose. I mean, some of the companies really do have a pretty diverse portfolio, that and again, I'm not the surgeon having to get this in, so maybe this is
Mm-hmm.
very easy for me to say, but I really feel like there is quite a diverse array potential, that most cochleas are able to, be successful in getting that array and having that more full insertion. I mean, we have a case where the array's in backwards, they can still hear. We're able to do it. You can flip how you have the channels allocated and everything. So, obviously I feel fortunate to work with very talented surgeons who are able to do that, but I feel like it's not often that we truly can't get it in, except for in situations where, there is no cochlea, in which case that is what it is.
Yeah, I feel like this. I'm very grateful. We work together. We deal with the same surgeons. I'm very grateful. I don't have to
Yes.
say. I'm very grateful. I don't have to say what I'm about to say ever. But something you could always say, like if they're like, oh, there's, you're like, I can map around it, right? Like that's the beauty of
Oh,
an audiologist. Like we could probably
yeah,
map around it. We'll figure
yeah,
out something for that, right?
yeah.
Cool. So just before we wrap things up, I'm curious if you have any other kind of upcoming projects, any other kids with arrays in their IAC that you need to tell us about and the amazing
Oh,
things you've done for them to hear. I know you were a part of a paper that was just put out that was kind of talking about when implants aren't where they're supposed to be. Is that a fair way to summarize that paper?
so are you talking, which paper are you talking about? The one
Well,
with,
no, it was about like misplacement of the array.
oh, yeah.
I guess
Oh,
it
yes,
was
yes, yes.
specifically reviewing misplacement into the
Yes.
IAC, right?
Yeah,
Not just your
absolutely.
single case, but maybe
Yes.
a review. Okay.
Yeah, and so what that was looking at was really just 4 cases where maybe the implant isn't where you would think it would be. It's just kind of how to handle them. And based on that literature review, which one of the papers reviewed was the original paper that I published about the kid in the IAC,
Hmm.
um, was, or the kids whose device was in the IAC, was to, if it's caught in the moment in surgery, to just try to revise it, pull it out, put a new one in, obviously kind of pending what happened. But that was kind of the recommendation. And then if it's caught afterwards, rather than immediately revising, to try this alternative mapping technique,
Mm,
try to see if you can map around it. Like you were saying, it's, as audiologists, like, let's map around it. Like
yeah.
maybe try that before you go to the surgical option. And then if that didn't resolve the problem, you could look at revising. So that's basically what the findings of that were between, and it looked at several papers. A lot of those were based on revision, but the ones that weren't revised, the papers that were published that weren't about revisions, that didn't use an alternative technique, pretty much across the board, the patients were not able to achieve open set speech perception, or eventually became non-users, and a lot of them did. So that was kind of where this new technique, we did achieve that open set. So that's where that recommendation came from.
Cool. Cool. So I'm looking forward to all of your upcoming work that tells us all the novel ways to map when things go awry and are in the place that they're not supposed to be. And I'm super grateful for you joining me for this. This has just been an awesome conversation. I'm very grateful that I get to chat with you about these things in a day-to-day context, but it's also fun to do it here too. And I know a lot of
Yes.
people are going to benefit from hearing what you have to say here. For those people who listen and have questions, or they've got that, that case that they just can't quite pin down, or they want to hear, how are you setting up ESRT in this situation? Like, what is that looking like? Is it okay for them to reach out? And if so, how could they best reach you?
Absolutely. The best way to reach out to me is through email. And so my email is melissa.anderson@unchealth.unc.edu.
Perfect. Perfect. Well, Melissa, it's been great talking to you. I look forward to seeing you tomorrow at work.
Sounds
And
good.
thanks so much for talking with me, and hope you have a great rest of your day.
Yes. Well, thank you for having me.
Do you enjoy listening to On the Ear but wish you could earn ASHA CEUs for it? Start today. SpeechTherapyPD.com has over 175 hours of audio courses on demand with an average of 19 new audio courses released each month. And here's the best part. Each episode earns you ASHA Continuing Ed credits. Oh, no, wait. This is the best part. As a listener of On the Ear, you can receive $20 off an annual subscription when you use code EAR21. Just head to SpeechTherapyPD.com to sign up and use code EAR21, EAR21, for $20 off your annual subscription. And that's all for today. Thank you so much for listening, subscribing, and rating. This podcast is part of an audio course offered for continuing education through Speech Therapy PD. Check out the website if you'd like to learn more about the CEU opportunities available for this episode, as well as archived episodes. Just head to speechtherapypd.com/ear. That's speechtherapypd.com/EAR.